Good morning, everyone. This is the recording of the first Pituitary lecture, which is focusing on hyperfunction. As I mentioned, there are a few slides that were hidden in the presentation that I gave last week, and you're gonna find those slides disseminated in this lecture. So I always start with three basic and important concepts in endocrinology. The first concept is that regulation of most endocrine systems takes place at multiple levels of command and response. This is what we call an axis. So how is the control exerted via positive and negative feedback? So when investigating such axes, one must evaluate all pertinent levels at the same time in order to have a better understanding of what's happening to the hormones. This generally helps us classify most endocrine disorders into primary or secondary disorders. So here is an example. This is the hypothalamic pituitary thyroid axis. The signal starts from the hypothalamus producing TRH, which stimulates the pituitary gland to produce TSH, which stimulates the thyroid gland to produce T4 and T3. Now, T4 and T3 exert negative feedback on the pituitary, suppressing TSH production. This eventually leads to a balanced state where we have normal TSH and normal free T4 levels. Abnormalities in that axis may lead to either high TSH, low free T4, or high T4, low TSH, depending on the situation. So primary hypothyroidism, for example, is when the problem is in the thyroid gland itself. It's unable to produce T4 and T3. Therefore, you will end up with high TSH because T4 and T3 are low. They're not able to exert negative feedback on the pituitary, which results in elevation in TSH, trying to stimulate the thyroid gland to produce more hormones. Secondary hypothyroidism, the problem is in the hypothalamus or the pituitary. So, for example, if we have a big pituitary tumor causing lack of TSH producing cells, then we will have no signal to stimulate the thyroid gland, and the end result is low TSH and low free T4, what we call secondary hypothyroidism. The second important concept is that most hormones are produced in a cyclical fashion. Most follow a circadian rhythm, which is about 24-hour cycle. Some are more pulsatile with frequent spikes during the day. Now, understanding those rhythms is important for diagnosing endocrine disorders and interpreting lists. This is an example of the higher graph is an example of cortisol production, and the black bar at the bottom is the early hours of the morning, between midnight and 8 in the morning, as you can see. That's where you have the peak of cortisol secretion, and as the day goes by, that level decreases. The lowest level is around midnight. So it's important to understand the circadian rhythm of cortisol production in order to interpret test results that depend on that hormone. The bottom graph shows you the pulsatility of LH depending on the GnRH pulses. So LH is produced following a pulse of GnRH. And you can see that in the lower graph. So each pulse of GnRH will eventually lead to a pulse in LH. And remember that both these hormones are pulsatile in nature. The third important concept is whenever investigating an endocrine problem, start with biochemical screening or confirmation tests first. Then proceed to anatomic localization. This concept reduces chances of errors and confusion, as well as unnecessary imaging and procedures. So anytime you're dealing with a patient who might have an endocrine problem based on history and physical examination, we start with biochemical testing or lab tests, whether it's blood or urine or other things. We have a lot of screening tests for certain disorders, then we have confirmatory tests for those disorders, and once we confirm a diagnosis, we start looking for the anatomic location of the problem. Example, when suspecting Cushing syndrome, which is excess of cortisol production based on history and physical examination, you start with screening tests. And we mentioned in our lecture, and we're going to mention today, that there are 3 screening tests that we utilize. If those screening tests were positive and we identify if, for example, in the case of Cushing syndrome, if it's ACTH dependent or ACTH independent, we proceed to confirmatory tests. If the confirmatory test was positive, we order imaging according to what the results, to where the results guide us, trying to look for the tumor or where the problem is. So the bottom line is we almost always start with biochemical testing, followed by imaging. Now, to start, here is the pituitary cross-section. The anterior part is the lower part, and the posterior part is the upper part. This is a cross-section of the pituitary gland, and you can see different areas of concentration of pituitary cells. For example, the most anterior proportion of the pituitary, of the anterior pituitary, is occupied by TSH-producing cells, which account for about 5% of all pituitary cells, anterior pituitary cells. Behind that, or posterior to that, is a concentration of ACTH-secreting cells, which comprise 10 to 20% of pituitary cells. On the lateral wings, we have anteriorly growth hormone cells and posteriorly prolactin cells, which account for about 50% and 30% respectively. And you can notice the absence of LH and FSH producing cells because they're scattered everywhere in the pituitary in general. Those are the gonadotrophs. These are 2 images. The left one is a sagittal and the right one is coronal, showing you normal pituitary structure. Unfortunately, I cannot use the pointer because it will screw up the recording. So we've mentioned this in the lecture before, and you can look at it in any atlas just to know the landmarks. But in general, we look for the pituitary, the size of it. It's bordered by the internal carotid arteries on both sides. The stalk is usually midline, and above the stalk is the optic chiasm. Now, pituitary hormones are under the influence of hypothalamic hormones, starting with the gonadotrophs, which are LH and FSH. Those 2 are under control of GnRH, gonadotropin-releasing hormone. And so GnRH will go into the pituitary, stimulating production of LH and FSH, which will go to the gonads in the male testicles and the female ovaries to produce sex hormones. The next axis is the thyroid axis, or the hypothalamus pituitary thyroid axis. It starts with TRH, thyrotropin releasing hormone, which stimulates the thyroid gland to produce TSH, and TSH stimulates the thyroid gland to produce the thyroxine. The next axis is the prolactin axis, which is under inhibitory signal by dopamine. So prolactin is again under inhibitory signal, and when that inhibitory signal is stopped, we have a rise in prolactin level, which goes to the mammary glands to promote milk production. The 5th axis is growth hormone axis, which is under control by growth hormone releasing hormone from the hypothalamus. And growth hormone will exert its effect directly on all body tissues, but it will go to the liver and produce from there the IGF-1, which also exerts some of the functions of growth hormone. Finally, the posterior pituitary, the ACTH axis, which is under control by the hypothalamus producing CRH. CRH is corticotropin releasing hormone. Goes to the pituitary, makes it produce the ACTH, and then the ACTH goes to the adrenal glands, stimulating production of cortisol. And remember that only cortisol is under the influence of ACTH. Other adrenal hormones are not under the influence of ACTH production, like aldosterone. The posterior pituitary, we're mainly interested in the antidiuretic hormone, which is stored in the posterior pituitary, and the target organ is mainly kidneys, and the effect is regulation of water balance. Oxytocin is of very little interest to us in the endocrinology world. It's of more importance probably in gynecology or obstetrics. So again, a recap: anterior pituitary hormones include prolactin, TSH, ACTH, LH, FSH, and growth hormone. The posterior pituitary hormones, or the posterior pituitary, produces mainly, stores the ADH, the antidiuretic hormone, or vasopressin. Those are the hormones of interest for us in the pituitary. Now, in general, pituitary disorders are classified into main categories, just like any other organ. So we have tumors, we have cancers, we have congenital disorders, we have inflammatory disorders, and then trauma or infarction. Pituitary tumors basically are because they will lead to either overproduction or underproduction of hormones, and we're going to discuss this later. Pituitary cancer, luckily, are extremely rare. But secondary pituitary cancers coming from different sites, like colorectal cancer or breast cancer metastasizing to the pituitary, are much more common than primary pituitary cancers. We just recently diagnosed a patient with metastatic thyroid cancer into the pituitary gland, which is a very rare event in the thyroid cancer world. The third point here is the craniopharyngiomas, and there are, in quotation marks, craniopharyngiomas are not cancers, but their behavior is somewhat aggressive, and therefore I put them under cancers, but they're not really cancers, but they just proliferate and recur rapidly, much more than regular pituitary tumors. Next, we move on to congenital disorders. There are many congenital disorders that can affect the pituitary gland. One of the common scenarios seen in pediatric patients is pituitary hypoplasia, and these people have certain genetic mutations leading to malfunctioning pituitaries, and they're replaced with hormones during their childhood, and then they graduate into adult care, and they come to us with this type of diagnosis. Next is inflammation. Inflammatory conditions can lead to pituitary problems, and one of the main examples is lymphocytic hypophysitis, which we're going to talk about later in this lecture. Another example of infiltration is sarcoidosis, which is again very rare. Next is infarction and trauma, and you're all familiar with Sheehan syndrome, which is infarction postpartum. In our world, the more important problem is infarction of pituitary tumors. So the bigger the pituitary tumor, the more likely that it may spontaneously infarct, leading to apoplexy and its syndrome. So that is more commonly what we see in our world. Of course, you can have also cases of infarction that lead to idiopathic hypogonadism and some other deficiencies as well. So let's start with pituitary tumors. It's very important to know that pituitary tumors are benign. The overwhelming majority of pituitary tumors are benign. So we're not dealing with a problem of cancer. We're dealing with a benign problem that is causing issues to the patient, whether hormone excess or hormone deficiency or mass effect. Pituitary tumors are common. They're estimated to be 1 in 5 people. This data mainly comes from autopsy data, and those tumors seen in autopsies are very small, microscopic really, not microscopic, I mean very small, in 1 or 2 millimeter range. In general, they're usually non-functional and do not cause any problem for the patient or for the person throughout their life. They're just discovered on autopsy. So again, the message is that pituitary tumors are common. Pituitary tumors may produce excess hormones or lead to hormonal deficiency or both, and we're going to talk more about this later. And they can cause also mass effect locally. Remember, the space in the skull is very, very narrow and limited. So small expansion in size of any structure might lead to problems in the nearby structures. Unlike, for example, the abdomen, which is a very big and extendable space, so you can end up with very large tumors without causing mass effect locally. That is not the case for pituitary tumors because they live in a small area in general, or small space, and small tumor sizes can lead to problems within the confinement of the skull. So the main issues include visual field disturbances or headaches or cranial nerve compression. This is a cross-section of the cellular area. This is a coronal view. And you can see at the top the yellow structure, which is the optic chiasm, and then the purple structure is the pituitary with its stalk cut. Bilaterally to that, you can see the internal carotid artery, which is a U shape. So it has, the cut section will show you two arteries, but it's just one, basically making a U-turn posteriorly. So you can see two structures on the right and two structures on the left. And then we have the cranial nerves dispersed into the cavernous sinus. The cranial nerves are the yellow structures, and the cavernous sinus in general is the blue structure. And inferior to the pituitary is the sphenoid sinus, which is the pink structure. And that's, compare this image to the pituitary MRI that is shown in the above right corner. Now, adenomas in the pituitary are classified into micro and macro, and the cutoff of 10 millimeters is generally because 10 millimeters or less are very unlikely to cause structural problem or mass effect, but bigger than 10 millimeters might cause mass effect to the nearby structures. That's one of the reasons why we chose 10 millimeters. So 10 millimeters or less than 10 millimeters is considered to be a microadenoma, and more than 10 millimeters or equal to 10 is a macroadenoma, and you can see the respective pictures. Visual field analyzers are used by ophthalmologists in order to map the visual fields. Typically, pituitary adenomas will caused by temporal hemianopsia, and this is shown next. Well, it's shown here, and the right eye is on the right, the left eye is on the left, and you can see the lateral part of the visual fields affected more on the right side, and that is because of a pituitary tumor. So in terms of prevalence of pituitary tumors, there are different reference studies that we go back to, and thus you find different numbers in different books. But in general, the most common secretory tumor is the prolactin producing tumors, and they compete with non-functional adenomas, which is more common in general. Growth hormone adenomas are rare compared to, they're less common, let's put it that way. Growth hormone and prolactin co-secreting tumors are often seen, and here, according to this study, they represent 7% of pituitary tumors. ACTH producing tumors are about 10%. Gonadotroph cell adenomas, which are classified typically as non-functioning as well, by the way. They represent about 10%. Non-functioning adenomas, 25%. The least common of all are the TSH producing adenomas, and I've seen in my career about probably 2 patients only with this condition. They're very uncommon. And finally, unclassified adenomas. So let's start with the first secretory tumor, which is the prolactinoma. Prolactin secreting pituitary adenomas, most common secretory pituitary tumor, and they're more common in women. How do these present? Well, the presentation is a bit different between men and women. The tumor biology is the same. However, women typically present to medical attention a bit earlier than men, not a bit actually, probably much earlier than men, mainly because hyperprolactinemia, because of that tumor, will lead to menstrual irregularity. And women in general, if they have menstrual irregularity for a month or 2 or 3, they don't wait longer to go and see a physician, and who will discover that the patient has hyperprolactinemia and then the tumor. So their presentation is earlier compared to men. In women, galactorrhea represents 30 to 80%, or galactorrhea is present in 30 to 80% of women presenting with prolactinomas. They have menstrual irregularity and infertility. And because they present earlier, the majority are microprolactinomas at the time of diagnosis. In men, on the other hand, galactorrhea is uncommon, and mainly men will complain of impotence or infertility, and men tend to either neglect or not pay too much attention to these symptoms. They might relate hypogonadism symptoms to stress at work and other issues, so they typically present at a later stage. The majority of those tumors in men are macroprolactinoma at the time of diagnosis. Postmenopausal women have similar presentation to men because they don't have periods to be interrupted with hyperprolactinemia, and they might also present with visual field defects and headaches just like men, including hypopituitarism as well. So prolactinomas can cause hypogonadism in 2 ways. The first one is by suppressing GnRH. High prolactin suppresses GnRH, which will lead to suppression of LH and FSH, leading to hypogonadism. The other mechanism of hypogonadism in a patient with hyperprolactinemia is hyperprolactinemia due to tumors. Basically, large tumors can compress normal pituitary cells, leading to reduced functionality. Other pituitary hormones can be affected as well by large prolactinomas because of mass effect. And the most commonly affected hormone in macroprolactinoma is growth hormone. So you will have growth hormone deficiency in those patients. And this is true for other types of pituitary tumors as well. The most common tumor to be affected, or the most common hormone to be affected in such cases, is the growth hormone. ACTH and TSH, they're the last to be affected by large pituitary tumors. Okay, so coming to the diagnosis of prolactinomas, first we start with symptoms and signs which are suggestive of hyperprolactinemia, including amenorrhea, galactorrhea, headaches, visual field defects, and hypopituitarism. Then we measure the prolactin level. Microadenomas usually produce prolactin levels less than 200. Macroadenomas usually produce prolactin level more than 200. And remember that the normal range, on average, between men and female, because they have different ranges, but consider that 20 is the upper limit of normal for both for the time being. So we're talking about 10 times the upper limit of normal would be suggestive of macroadenomas rather than micro. Now, hormone level of less than 200 might either be because of microprolactinoma or other causes of hyperprolactinemia, which we're going to talk about in a bit. So pituitary MRI with and without contrast is the standard modality of imaging. We do not use CT scans nowadays for imaging the cellular area. Other causes of hyperprolactinemia are classified into physiologic causes like pregnancy, lactation, states of high estrogen, or people who are on treatment with estrogen. Stress and pain also lead to elevation in prolactin level. Pathologic causes for hyperprolactinemia include hypothyroidism, and it's not simple hypothyroidism, it's usually severe hypothyroidism, chronic kidney disease, and chest wall pathology. Chest wall pathology, anything that is affecting the nipple in general, like herpes zoster and other issues. Drugs Um, if you want to remember one category which is important that can cause hyperprolactinemia, it's the antipsychotics, whether typical or atypical. Less commonly, metoclopramide can also cause hyperprolactinemia, and one of the antihypertensive drugs like verapamil also is known to cause hyperprolactinemia. So anytime you see a patient with prolactin level, with elevated prolactin level, make sure that you rule out secondary causes for hyperprolactinemia. And eventually, pituitary tumors that are producing prolactin are in the differential diagnosis as well. Now, again, dopamine or prolactin is under constant inhibition by dopamine, which is produced from the hypothalamus. Dopamine inhibits prolactin release or controls it. So if there's any interruption to this signal through the stalk, then we will end up with hyperprolactinemia. And this is what we call the stalk effect. And you can see here in the picture, the arrow is pointing to a thickened stalk because of an infiltrative disease, for example. And this will lead to interrupted dopamine signal from the hypothalamus to the anterior pituitary, resulting in hyperprolactinemia. Stalk effect does not produce prolactin levels more than 200, following the same rule we discussed a bit earlier. Now, how does chest wall or breast stimulation induce hyperprolactinemia? Well, it's through inhibition of the dopamine. And you can see the bottom left part of the diagram. There is a spinal afferent going and negatively affecting the dopamine, which will lead to release of prolactin and eventually release of breast milk, for the example of nursing mothers. So looking at this picture, what do you think is the cause of hyperprolactinemia? Well, the cause here is mainly the nipple piercing. And remember, we said that chest wall affection can cause hyperprolactinemia. Actually, this had been studied. Does nipple piercing cause how does it cause hyperprolactinemia? It typically does that initially after the nipples are pierced, but then when the local inflammation heals, prolactin levels go back to normal. Now, treatment. How do you treat patients with hyperprolactinemia? The main treatment is dopamine agonist, and we have older dopamine agonist, which is called bromocriptine, and the newer one is called cabergoline. Bromocriptine fell out of fashion nowadays because it has more side effects. It's taken twice daily, and compared to cabergoline, which is much more effective and taken once or twice a week, and reduces the size and the size of the pituitary tumor that is producing prolactin, and also normalizes the prolactin level much more effectively. Remember, when you're treating a patient with prolactinoma, not only focusing on the prolactin level, but we also treat other hormonal deficiencies if they are present. One exception to keep in mind is that hyperprolactinemia, because of a prolactinoma, might lead to hypogonadism by suppressing LH and FSH in a central fashion. So it's worthwhile to treat patients with prolactinomas with cabergoline first, and watch them over time, and follow their testosterone, for example, or estrogen without treating, because the reduction of prolactin level might release or might stop the inhibition of the gonadotrophs, leading to restoration of the LH and FSH signal that will stimulate the gonads normally. So I do not rush in general to treat hypogonadism in patients who have prolactinomas. I start first with cabergoline, and I follow the patient over several months to see how their gonadotrophic axis responds to suppression of prolactin. If that axis did not improve over time, then I can offer the patient treatment with either testosterone or estrogen. There is very limited role for surgery and radiation therapy in patients with prolactinomas, because the tumors are very responsive in general to cabergoline therapy. As mentioned before, there is reduction in tumor size, and there is also normalization of prolactin level with cabergoline therapy. In rare cases where the tumor does not shrink significantly, or the tumor is resistant to cabergoline therapy, we might revert to surgery or radiation, depending on the situation. So here is an example of a giant prolactinoma in a patient, and the next picture shows a significant reduction in tumor size by only giving the patient cabergoline. And this patient did not require surgery to debulk his tumor. Even visual field compromise in patients who are confirmed to have hyperprolactinemia typically responds to medical therapy. So again, the role of surgery is somewhat limited in patients with confirmed prolactinomas. How do you monitor the effect of treatment? Well, we follow prolactin levels, and we also perform MRIs to follow up the pituitary tumor size as needed. In cases of microprolactinoma, meaning prolactin producing pituitary tumors that are smaller than 10 millimeters, those patients might be cured if they were treated with cabergoline for 2 years. So what happens is we treat them with cabergoline for about 2 years, and then we start tapering the cabergoline to discontinuation. We repeat the pituitary imaging, and if there is no tumor on MRI with normal prolactin level after stopping cabergoline, there is a good chance that this patient is cured from this tumor. Now, recurrence does happen, and we have to monitor these people for a long time if they were in remission. Now, moving on to the second secretory tumor, which is growth hormone secreting adenomas. The condition is called acromegaly, and it's because of pituitary adenomas in more than 95% of cases. I've never seen acromegaly because of ectopic tumor. All the cases that I've seen are because of adenomas in the pituitary. Macroadenomas account for 75% of patients presenting with acromegaly. The average number of years between the onset of symptoms and diagnosis is about 10 years. So patients usually have low suspicion, or they don't present to medical attention, or maybe they're not picked up early on when they present with non-discrete symptoms to their physicians. It's estimated that about 10 years will pass from the first sign or symptom actually of acromegaly to the time of diagnosis. There are of course cases that present much later, and there are those lucky ones which present much earlier without the full manifestation of acromegaly. Growth hormone excess that occurs before puberty leads to pituitary gigantism because the fusion of the epiphyseal plates does not take place yet before puberty, so they tend to grow very significantly to become giants. In the adult world, of course, we don't see this because pituitary tumors that arise after puberty just lead to the characteristic features of acromegaly without gaining any further height. Remember, any pituitary tumor could be part of multiple endocrine neoplasia type 1 or other syndromes, and we're going to talk about these syndromes in a future time. Symptoms and signs of acromegaly, again, for lack of better illustration, and I encourage all the artists in your group to come forward if they're interested to work with me into drawing something a bit more professional. Anyway, these people present with the characteristic features that you see in the books, with large tongue, spacing between the teeth, coarse facial features, thyromegaly. They can have hypogonadism leading to gynecomastia, cardiomegaly, arrhythmias, hypertension, diabetes, organomegaly, so many different, and of course sweating, also spontaneous sweating, obstructive sleep apnea, arthritis, many conditions can happen in these people. And I'm emphasizing here some features which include arthralgia, excessive sweating, hypertension, congestive heart failure, and arrhythmia. And cardiac complications are the most common cause of death in patients with acromegaly. And those patients also have snoring or obstructive sleep apnea because of soft tissue. Here is a picture of a young man over the years, and you can see the progression of acromegaly and the change in facial features associated with acromegaly before he was eventually diagnosed much later. Here is a picture of a woman with acromegaly, and you can see how big the hand is. It's described as doughy, from the dough, doughy handshake, because of soft tissue swelling, and also the enlargement of the shoe size as seen in the picture. And these people have also thick heel pad, which used to be a modality of diagnosis to order a lateral x-ray of the foot. We don't do it anymore. It's a legacy thing, or an interesting historical fact. Now, effects of growth hormone, variable effects, of course, on all the body. Some of them are through IGF-1, and some of them are through direct effect. We know that growth hormone is a counter-regulatory hormone, which counteracts the effect of insulin. I'm not going to go through this. You can read it at your own time. Diagnosis: IGF-1 is typically elevated. So if you have a patient who comes to your clinic with features of acromegaly from history and physical examination, the first thing that you need to order biochemically is the IGF-1 level. It's the single best test for acromegaly. Growth hormone level is not commonly utilized for the diagnosis of acromegaly because it's pulsatile. So at one point it can be normal, at another point it can be elevated, and there is no cutoff beyond which we say that this is 100% acromegaly, except in really, really high numbers. So again, it's pulsatile and not frequently used for the sake of diagnosis. Now, in classic cases of acromegaly, where you have very convincing features of acromegaly, and then you have elevated growth IGF-1, elevated IGF-1, 3, 4, 5 times the upper limit of normal, then you have a confirmed diagnosis. You don't need to do confirmatory tests. In other situations where you have very little features of acromegaly on clinical examination or by history, and you have a borderline elevated IGF-1, or maybe 1 or twice the upper limit of normal, it's best to confirm your diagnosis by doing the growth hormone suppression test. In normal physiology, if you give glucose to a person, the glucose will suppress growth hormone release. This is the normal physiology. If you have somebody who has elevated growth hormone because of a tumor, you give them glucose, that tumor does not respond to physiologic stimuli or inhibitors. So the growth hormone will not be suppressed. That's why we utilize this test to distinguish between normal people and those with growth hormone excess because of a tumor. So if you give them, it's just like the oral glucose tolerance test. If you give them 75 grams of glucose and you keep measuring their growth hormone serially, those with suppressed growth hormone, we can rule out acromegaly in those patients. Those who do not have suppressed growth hormone are considered to be positive cases. Of course, after we do the biochemical testing and we do the confirmation, we move on to anatomic localization, and the best way to investigate these people is by obtaining a pituitary MRI to determine if it's a micro or macro adenoma. So this is just a recap of what we discussed earlier. Other important tests, because the majority of patients with acromegaly present with macroadenoma, you should anticipate or look for mass effect conditions like visual field disturbances. You also look at their thyroid because they have thyromegaly. They might harbor nodules which might require further investigation. You do echocardiograms to look at the heart because they can have cardiomegaly or left ventricular hypertrophy. And also you do colonoscopy for these people because they have higher chance of developing polyps which may be cancerous. So the mainstay of treatment of a patient with acromegaly is surgical. So we refer them to an experienced neurosurgeon to resect or debulk a large tumor. Cure rate for microadenomas is up to 90%, meaning that a skillful surgeon can take out the whole pituitary tumor without affecting the remainder of the pituitary gland and succeed in 90% of cases. However, macroadenomas have lesser rate of cure even in experienced hands. If cure was not achieved by surgery, then medical therapy is indicated, and cure is typically defined by normalization of IGF-1 level and low growth hormone level. Remember that IGF-1 level should not be measured immediately after surgery. It takes several months to come down after surgery, so we don't measure it typically before 3 months from the time of surgery. So medical therapy, we have somatostatin analogs, which we utilize, including octreotide and lanreotide, and we have dopamine agonist, which is cabergoline, and we have growth hormone receptor blocker, which is pegvisomant. So how do we choose which one to treat those patients? The mainstay of treatment is octreotide, which is available in our hospital, and of course there's also lanreotide. Those are monthly injections that are given to the patient, and they typically lead to reduction in the growth hormone level and IGF-1, and they may also lead to some shrinkage in the tumor size. Now, if we have a borderline case of acromegaly or mild case of acromegaly, we might start with cabergoline because in about 20% of cases, the patients will be controlled by cabergoline alone. Now, cabergoline has the advantage of being a bit cheaper, and it's an oral medication rather than an injectable medication. So if a patient would be controlled by cabergoline, then that is good. If not, then we revert to octreotide. But again, the main type of treatment for acromegaly is somatostatin analogs, not dopamine. So dopamine is restricted to a small proportion of mild cases. Now, if you fail to control a patient with octreotide, even by maximizing the dose to the maximum tolerable or allowed dose, there is room to add another form of treatment, which is growth hormone receptor blocker, pegvisomant. This is also an injectable medication which is taken daily, and it's extremely expensive. So, sometimes we have to do that in order to control the IGF-1 levels in those patients. Radiation therapy is somewhat a deferred option. If a patient underwent surgery and was not cured, then we started somatostatin analogs, maximized the dose, still not controlled. Maybe we can add growth hormone receptor blocker if it's available, still not controlled, then we revert to radiation therapy. In general, pegvisomant is not commonly used, so we revert to radiation therapy sooner. And radiation therapy will take at least a year to show its effect. So we have to plan radiation therapy early on if we think that the patient is not going to be controlled by somatostatin analogs. So what improves after curing acromegaly? Mainly hypertension, diabetes, soft tissue swelling, excessive sweating, obstructive sleep apnea. These all improve. However, bony changes do not improve, meaning the facial features will improve a bit just because of less soft tissue swelling, but they will not improve drastically or dramatically. Arthritis, for example, is something that we do not anticipate improvement in. And life expectancy of cured patients is similar to the general population. Remember that untreated patients, they have 2 to 3-fold increase in mortality due to cardiovascular disease. Moving to the third secretory type of pituitary tumors, which causes Cushing disease. And here I want to talk about the difference between Cushing disease and Cushing syndrome. The bigger umbrella is the Cushing syndrome. So Cushing syndrome means elevated cortisol level because of any cause. However, when we say Cushing disease, it's elevated cortisol due to an ACTH producing pituitary adenoma. So remember this distinction. Signs and symptoms of Cushing syndrome include the things seen in this interesting diagram. So At the top left, you have a little buffalo with a hump. I just want to remind you that we don't use the word buffalo hump anymore. It's not appropriate. We use the term dorsocervical fat pad. Those patients also have supraclavicular fullness, moon face, acne, plethora in the face, which is redness of the face. Females can have hirsutism, obesity, diabetes, hypertension, osteoarthritis, thinning of the skin, purple striae, potential or predisposition to deep vein thrombosis and pulmonary embolisms, a lot of complications. Of course, the mood, these people have very labile mood, and they tend to be depressed. It's a very, very nasty disease to have. Some of the features here shown, the purple or the red striae on the abdomen and other areas in the body, which are thick, not thick, they're wide and violet or red in color. On the right hand side, you can see the moon face, the obesity, supraclavicular fullness, hirsutism, maybe some plethora in this female. Okay, so presentation. How do these people seek or come to you, basically? Maybe those are patients who had diabetes or hypertension for some time, and all of a sudden they become uncontrolled. So that's one of the signs that would alert a physician to look for secondary causes of uncontrolled hypertension or diabetes mellitus. Maybe somebody can present with a significant obesity with some other features of Cushing syndrome that lead to the diagnosis. Patients presenting with incidental adrenal adenomas, they're worked up, and we can confirm sometimes Cushing syndrome. If I see osteoporosis in a young person, I start looking for secondary causes because it's not common in this age group, and we can pick up cases of Cushing syndrome that way. And of course, self-referral. A lot of patients suffer from many symptoms and signs for years before they are diagnosed. So people revert to Google and other formats online to try to classify or try to put things together and come up with a diagnosis, and they come to you with a self-diagnosis of Cushing syndrome. And from experience, it's very hard really to convince them that they don't have Cushing syndrome and that those symptoms can be explained by other things. So self-referral is an important stream nowadays of patients coming to our clinics. So testing for Cushing syndrome, I have to warn you here that testing is very confusing. All right, so if we follow a very strict plan, that will make our life very easy. All right, so remember, Cushing syndrome, we start with screening tests first. There are 3 types of screening tests which I'm going to discuss. After those screening tests, we move to ACTH level, and by that we can determine if the patient has ACTH dependent Cushing versus ACTH independent Cushing, and then we start digging further. Okay, so the first line of tests are the 3 screening tests: the dexamethasone suppression test, the midnight salivary cortisol, and the 24-hour urinary-free cortisol. So the way to do the dexamethasone suppression test, so the way to do the dexamethasone suppression test is we give the patient oral tablets of dexamethasone. They take it at night, and they come to the lab the next morning for a blood test. We measure their cortisol the next morning. Now, dexamethasone is supposed to suppress your cortisol production. So that's the normal physiology. So if somebody takes dexamethasone at night, which is 1 milligram, the next morning their cortisol level should be very low, and there is a cutoff for that. If the patient does not have this suppression, it means that there is another reason, or there is an autonomous production of cortisol, and that is considered a positive test. The second screening test is midnight salivary cortisol. In normal physiology, as we mentioned before, the cortisol in the morning is high, and then it decreases as the day goes by, and the lowest value or the lowest level of cortisol is typically before going to bed. So if we measure cortisol level at midnight, it should be low in normal people. However, in patients with Cushing syndrome, it is elevated. And that is because of this autonomous production. But because we cannot go to people's homes and obtain blood samples, we measure cortisol level in their saliva, because there is a proportional amount of cortisol in the saliva proportional to the blood. So we give them tubes, and we ask them to put saliva in those tubes just before going to bed, and we collect several samples and we run the test, and if those samples come back with elevated cortisol levels, and that is another positive screening test. The third screening test is 24-hour urinary free cortisol. We excrete cortisol in our urine, so if we collect 24-hour urine for the whole day, we will find high cortisol levels in those with Cushing syndrome. So any 2 out of those 3 screening tests, if they were positive, then we proceed to the next step. And we explained the basis of those tests just now. So after screening, and we have to select at least 2 of those screening tests, we move on to ACTH level. ACTH level will help us differentiate ACTH dependent versus ACTH independent Cushing syndrome. So ACTH dependent Cushing syndrome, there are 2 main conditions: either Cushing disease because of a pituitary producing a lot of pituitary tumor producing a lot of ACTH, or ectopic ACTH reduction, mainly something like small cell lung cancers and that sort of thing. So those are the 2 main reasons for elevated ACTH level or inappropriately normal ACTH level. Moving on to the ACTH independent Cushing syndrome, if you measure the ACTH in those patients, it will be suppressed, and the most common cause is medications. Steroids basically leads to suppression of ACTH, and the second important diagnosis is adrenal adenoma, producing too much cortisol. Those 2 conditions, exogenous cortisol and adrenal mass producing too much cortisol, will lead to suppression of ACTH, and that's what we call ACTH independent Cushing syndrome. I'm not going to move on to pseudo-Cushing at the bottom of this table, but we see something called pseudo-Cushing in major depressive disorder and in alcoholics, and there are certain tests to diagnose these people, which I'm not going to allude to. So in cases that we have ACTH dependent Cushing syndrome, we have to look for either we have to look at the pituitary or the other places where the ectopic production of ACTH can be found, mainly in the chest. So we either do a pituitary MRI or we do CT scan of the chest, and we also imply other dexamethasone suppression tests, which are considered either the high dose, the 8 milligram. I'm not going to go into those details because they're beyond the scope of our lectures. If you have somebody with ACTH independent Cushing syndrome, we have to look at the adrenals, and we typically we can find tumors there that are leading to this condition. If you don't find anything on a CT of the abdomen, then the most likely diagnosis is exogenous steroids. You ask your patient to list all the medications that he or she takes, including herbal remedies from their neighbors, or God knows where they're getting things, because sometimes there are steroids hidden in these preparations. Also remember to ask them about injectable steroids. People get injectable steroids for their discs in their back, or maybe arthritis in their joints, and that will lead to Cushing syndrome on the long term if repeated injections were utilized. This is a bit complicated. You can try to understand it. I don't care about the cutoffs, by the way, so don't remember any specific number for cutoffs, but it might just explain a few things. IPSS is what we call inferior petrosal sinus sampling. It's a method that we utilize to distinguish between the 2 causes of ACTH-dependent Cushing, the Cushing disease, which is the pituitary, versus the ectopic, because both of these conditions lead to high ACTH values. So IPSS, there is insertion of catheters into the jugular vein going to the cavernous sinus surrounding the pituitary, and both sides, of course, right and left, and we measure ACTH levels from there, and we compare those levels with peripheral blood. if the inferior petrosal sinus sample of ACTH gives us higher ACTH level compared to the peripheral blood sample, this confirms that the secretion is coming from the pituitary. On the other hand, if the inferior petrosal sinus sample ACTH level is equal to or similar to the one coming from the periphery, then this is most likely ectopic ACTH production. Some considerations that distinguish ACTH that distinguish ectopic from pituitary. Potassium is low in 95% of patients with ectopic ACTH syndrome because the ectopic tumors produce very high amounts of ACTH in general. On the other hand, potassium is low in only 10% of cases with Cushing disease. In ACTH-dependent Cushing, males are more likely than females to have ectopic disease. So if I have a female patient with Cushing syndrome, ACTH dependent, it's much more likely that she has a pituitary origin for this tumor rather than ectopic. In males, we stress on looking for ectopic a bit more than females. So what is the most common cause of Cushing syndrome in general? Iatrogenic, drug-induced, basically doctors over-prescribing steroids, or maybe legitimately prescribing steroids to control other diseases, but ultimately leading to Cushing syndrome. The second most common overall cause of ACTH, the second most common overall cause is ACTH-producing pituitary adenoma. And in these two graphs on the left side, you can see the arrow pointing to a microadenoma, and on the right side, you can see a big tumor, which is also a macroadenoma producing ACTH. The arrow is pointing to the internal carotid artery, which is encased by this tumor. Ectopic ACTH syndrome is looked for in general first in the lungs, and you can see the point. So the arrow is pointing to that tumor on the chest X-ray in A, on the CT scan in B, and on the CT scan in C, and then the 3D reconstruction in D. Adrenocortical carcinoma causing Cushing syndrome. The arrow is pointing to a large tumor in the adrenal gland, and this is cancer until proven otherwise because of its size, and it's a very nasty disease. But adrenocortical carcinoma can be functional, producing cortisol. So what is the expected ACTH level here? The expected ACTH level is low because this is ACTH independent situation, and of course the survival of the patient is somewhat poor because of this large tumor or cancer, large cancer. So how do we treat Cushing syndrome? First, go through the steps, identify, make sure that you have the right diagnosis, that this is Cushing syndrome, and then identify the cause of the disease. If it's pituitary, we refer those patients for transsphenoidal surgery. If it's ectopic, you need to send the patient for tumor resection. If it's adrenal, we do adrenalectomy, and if there is no focus or other situations that we cannot really cure those patients, we can revert to bilateral adrenalectomy. There might be need also for medical therapy and radiation therapy. So if you send the patient with Cushing disease to surgery, the surgeon or the neurosurgeon will resect the tumor. The neurosurgeon will resect the tumor, and that will lead to low cortisol levels the day after surgery. If cortisol level the next day after surgery becomes very low, this confirms cure. Now, why is that the case? Remember, this is a tumor producing too much ACTH. Now, because of the overproduction of ACTH, from that tumor, the normal ACTH producing cells in the pituitary are suppressed because of negative feedback of cortisol. When you remove that tumor secreting too much ACTH, the normal ACTH cells in the pituitary are still asleep. I'm using that term freely, are still asleep. So they will need time to start waking up after removal of the ACTH secreting tumor. So therefore, if you do not replace the patient if you do not replace the patient with steroids after surgery, they will have an abrupt decline in cortisol levels, which will lead to adrenal insufficiency. So you have to treat those patients with steroids. We give them higher than normal steroids for a long period of time, sometimes up to 9 months, in order for their axis to wake up, and then we can taper down the steroids and stop the treatment. So this is a Cushing disease story. Twin sisters, and the one on the right hand has features suggestive of Cushing syndrome. The tumor actually in this patient was not identified, and the treating physician reverted to bilateral adrenalectomy for this patient. Several years later, she presents with this picture. She has ptosis and mydriasis, indicating cranial nerve entrapment. Imaging showed this large cellular area tumor, which is causing right-sided cavernous sinus invasion and compression of the nerves, cranial nerves. And eventually, after a surgical resection of that tumor, she continued to have elevated ACTH production, and ACTH will lead to bronze skin because it stimulates melanocytes, basically. So again, just to recap, the story here is that this is a patient with Cushing disease initially, but the Cushing disease was not easy to diagnose initially. So the treating physicians reverted to bilateral adrenalectomy, and when you remove the adrenal glands in such patients, the tumor, the pituitary tumor, tends to grow much rapidly. So this growth led to the presentation of this patient and the bronzing of the skin. ACTH needs the adrenal glands to cause Cushing syndrome. If you remove the factory of cortisol, which is the adrenal gland, you solve the problem of Cushing syndrome. However, you have to deal with the pituitary tumor, which is producing too much ACTH and might cause mass effect. So this patient required surgery to remove or to resect that pituitary tumor. This is what we call Nelson syndrome. So Nelson syndrome, patients with Cushing disease who undergo bilateral adrenalectomy run the risk of Nelson syndrome. The small ACTH pituitary adenoma or unresectable remnant will lack sufficient cortisol negative feedback. This leads to progressive elevation of ACTH level and tumor growth, which is invasive, often requiring surgery or radiation therapy. Patients typically develop skin pigmentation due to high ACTH levels. Going back to medical therapy for Cushing disease, or let's put it in general, Cushing syndrome, we can utilize ketoconazole, which inhibits cortisol and androgen synthesis. We can utilize pasireotide, which is a somatostatin analog, and this is a new drug in the market. It blocks somatostatin receptor 5 in particular, that binds to somatostatin receptors and inhibit ACTH secretion. And we also have mifepristone, which is a cortisol receptor blocker. You might remember that mifepristone is also used by gynecologists to induce abortion, but we also use it in endocrinology to, in higher doses of course, to suppress or to block cortisol receptors. This is a diagram just to show you the ACTH levels in Cushing syndrome. The first bar on the left side is Cushing disease, and you can see that patients with Cushing disease have variable levels of ACTH. Some of those patients will be in the normal range, and some of those will be higher than the normal range. If you look at the ectopic ACTH, which is the farthest on the right, people in general will have high ACTH above the normal range, and the middle column Adrenal tumors causing Cushing's syndrome, those patients typically have suppressed ACTH production, and it's usually below the normal range. So in Cushing disease, there is overlap in the ACTH level between the normal range and the elevated range. Moving on to the last type of secretory tumor, which is the TSH producing adenoma. It's the least common among all pituitary tumors, and as I've mentioned, I've seen only 2 cases in my career so far. Patients present with hyperthyroidism and pituitary adenoma. Hyperthyroidism, classic features, when you do the testing, you will find that they have elevated TSH, and they will also have elevated T4 and T3. Patients also have a goiter because the high TSH stimulates growth of the pituitary gland. It's worth mentioning that often this disease is mistaken for Graves' disease, and the patients may receive inappropriate treatment, including radioactive iodine or surgery to resect or to treat the hyperthyroidism, but this unfortunately makes the tumor more aggressive in nature. The pituitary tumor becomes more aggressive in nature. So investigations, again, elevated T4 and T3 with elevated or inappropriately normal TSH. Alpha subunit is also elevated, and MRI is utilized to identify the tumor in the cellular area. This is just a quick diagram to explain what is the alpha subunit. There are 4 hormones which are called glycoprotein hormones: LH, FSH, TSH, and HCG. These 4 hormones are formed of 2 subunits. One subunit is called alpha subunit, and the second one is called beta subunit. The uniqueness of each of these hormones is due to the beta subunit. So the beta subunit is unique in all 4. However, those 4 hormones share the same alpha subunit. And you can see that the alpha subunit is in blue, and the beta subunit is in green. So that's why we call it beta HCG. If you ever read in the books beta HCG, why do we call the test beta HCG? Because what they're measuring really, or what they're trying to detect by doing the test, is the beta subunit, because that's the unique subunit distinguishing this glycoprotein hormone from the other 4 glycoprotein hormones. Now, in patients with TSH producing adenoma, the TSH cells in the tumor are not very effective in synthesizing TSH, combining the alpha subunit with the beta subunit. So there is formation of TSH, which is the combination of the 2, and there is also a release of unbound beta subunit and unbound alpha subunit into the circulation. That's why you will have elevated alpha subunit level if you do the test, which will lead you to or help you in diagnosing TSH secreting pituitary adenomas. The other differential diagnosis for elevated TSH and elevated T4 is thyroxine resistance, and in those cases the alpha subunit is not raised. How do you treat TSH producing adenomas? Again, the first line of treatment is surgical. We try to resect that tumor. Success rate in microadenomas, as usual, is bigger than success rate of macroadenomas. If the surgery was not curative, then we revert to somatostatin analog therapy. So that's the end of our first pituitary lecture. Please feel free to send me any questions by email, or maybe in our large group discussions later this week. Thank you very much.